A 67-year-old male with a history of unresectable pancreatic cancer presented to our emergency room with fatigue. When the patient was originally diagnosed with cancer, he was also found to have gastric outlet obstruction, which was managed with a laparoscopic gastrojejunostomy. For this presentation, the patient's outpatient oncologist recommended that he come to our ER for evaluation once he developed worsening fatigue and had lab abnormalities concerning for biliary obstruction. Upon presentation, a CT of the abdomen and pelvis was obtained, which demonstrated biliary ductal dilatation with a dilated common bile duct concerning for biliary obstruction. There was also a large mass at the pancreatic head with associated compression of the duodenum. An upper endoscopy was performed, which confirmed the complete obstruction of the duodenal lumen through which a duodenoscope could not be passed to reach the ampulla. The decision was then made to attempt biliary drainage via a colodocoduodenostomy. The common bile duct was visualized under endoscopic ultrasound, and a fine needle puncture was performed. With the needle in place, contrast was instilled to distend the common bile duct, and the duct was further visualized under EUS and fluoroscopy. The total diameter of the distended duct was measured at 12 to 13 millimeters, which was below the threshold of 20 millimeters that these authors prefer for the safe attempt at colodocoduodenostomy, and the attempt was ultimately aborted. The decision was then made to attempt biliary drainage via a left hepaticogastrostomy. Endosonographic evaluation demonstrated multiple dilated hepatic ducts. Fine needle puncture was performed into the left intrahepatic duct. Contrast was then injected to confirm positioning. A 0.018 inch guide wire was passed into the intrahepatic ducts. Over the guide wire, a 3.5 millimeter angioplasty balloon was then passed into the ducts. What is unique here is that over the 0.018 inch wire, the angioplasty balloon is able to penetrate the wall of the stomach and enter the bile ducts without the need to perform any form of predilation. This is because the slim entry profile of the angioplasty balloon is similar to that of the 0.018 inch guide wire and smaller than that of the 19-gauge needle that was used to access the duct. In our experience with cysgastrostomy, usually predilation with an additional device is first needed in order to pass a standard 4 millimeter balloon through the gastric wall. In this ex vivo demonstration, the favorable characteristics of the angioplasty balloon are again highlighted. The angioplasty balloon, seen here in blue, compares favorably to the slim profile of the 0.018 inch guide wire and is noticeably slimmer than that of the standard 4 millimeter balloon, here colored white. However, despite its slimmer entry profile, the total diameters of both the angioplasty balloon and the 4 millimeter balloon are similar once fully inflated. This allows for effective dilatation using the angioplasty balloon without the need for an additional step of predilation in order to accommodate the thicker profile of the standard 4 millimeter balloon. Serial dilatation of the intrahepatic ducts was then performed. One major advantage of using the angioplasty balloon is that it allows for the identification and dilatation of intrahepatic strictures prior to dilation of the gastrostomy tract. Here, one such stricture is identified and dilated, facilitating passage of all subsequent devices. Once dilation of the intrahepatic ducts was complete, the angioplasty balloon was used to dilate the hepaticogastrostomy tract in order to allow passage of subsequent devices. An exchange catheter was then used to assist in the exchange for a 0.035 inch guide wire over which a balloon dilator could then be passed. The balloon dilator was used to then dilate the hepaticogastrostomy tract to 4 millimeters. Here, we see dilation of the hepaticogastrostomy tract itself using endoscopic ultrasound. For this procedure, the decision was made to use a 8 millimeter by 6 centimeter, fully covered, self-expanding metal stent with transmural drainage holes. The stent itself comprises both a covered portion with transmural holes to facilitate bile drainage, as well as a fully covered portion to reduce the risk of bile leak and peritonitis. In addition, the stent also possesses anti-migration shark fins to reduce the risk of stent migration. The stent was advanced through the newly created hepaticogastrostomy tract and deployed under endoscopic vision. Positioning of the stent was confirmed under fluoroscopy, with identification of both the covered portion, indicated here between the green and red arrows, and the covered portion, indicated between the red and black arrows. Positioning was further identified through contrast installation. Because of concerns that the proximal end of the hepaticogastrostomy stent was right against the gastric wall, the decision was made to coaxially place a second covered stent inside the original stent in order to secure positioning. Following the procedure, the patient had a dramatic improvement in his bilirubin levels, which decreased from a peak of 7 milligrams per deciliter to a nadir of less than 1 milligram per deciliter at 1 month post-procedure. The patient did well following the procedure and developed no adverse events. Once his liver test showed improvement, he was discharged home to continue cancer treatment. This case demonstrates the utility of small caliber devices, such as a 0.018-inch wire and an angioplasty balloon, for the endoscopic creation of left hepaticogastrostomy. This technique may reduce periprocedural adverse events associated with left hepaticogastrostomy that often result from the pre-dilation step, which often requires cautery or use of a step-up dilator. Additionally, the angioplasty balloon was well suited for managing a tight intrahepatic duct stricture, which otherwise may have disrupted stent placement. The use of a partially covered stent simultaneously minimizes the risk of bile peritonitis and occlusion of branches of the biliary tree.